Hey everyone, welcome back. I am so incredibly thrilled to have you all here. Today, we're tackling a major and honestly pretty fascinating shift in the ICD-10-PCS manual, specifically looking at the administration section. If you've been practicing your coding lately, you've probably noticed that some of your familiar, go-to temporary codes are, well, they're suddenly vanishing. They're getting moved right out of the temporary sections and dropped directly into the permanent administration tables. So in this explainer, we're going to break down exactly why this happens, look at the clinical science behind these codes, and show you how to confidently track these changes so you're absolutely never caught off guard, whether it's on an exam or just in your daily workflow. Okay, let's dive into this. On the agenda today, 1. The NTAP life cycle. 2. High-dose immune globulin. 3. NexoBrid for severe burns. And 4. Coding takeaways and updates. Section 1. The NTAP life cycle and why codes actually move. You know, medical coding isn't just some static book of numbers. It's a dynamic, living system that's totally driven by the adoption of cutting-edge technology. And that brings us straight to NTAP, or New Technology Add-on Payment. Basically, this specialized program provides temporary supplemental reimbursement to encourage hospitals to adopt these really costly innovations without taking a massive financial hit. I mean, let's face it, innovative medical technologies are incredibly expensive when they first hit the market. So the NTAP is designed specifically to make sure facilities can actually offer them to patients right away. Now, check out this number because you really need to understand it to grasp the whole concept. 65%. The NTAP program is so powerful because it covers up to 65% of a new technology's added cost. That is a massive supplemental reimbursement for a facility. But here's the catch, and it's a big one. It's strictly temporary. Eventually, that payment period ends. And when that NTAP expires, it forces a huge shift in our coding system. The technology is no longer considered new for payment purposes, meaning those temporary codes you've been using, they have to be deleted, and the procedures officially migrate over to the permanent coding tables. Moving right along to Section 2, High-Dose Immune Globulin and the Table 302 updates. So we're looking at Table 302, which covers administration, circulatory, transfusion. But to code this accurately, we really need to understand the clinical picture first. High-dose immune globulin, or hdIVIg, is a totally remarkable FDA-approved IV therapy. It uses concentrated antibodies, specifically IgG, collected from literally thousands of human donors. Now, you might already be familiar with standard low-dose immune globulin, right? That's typically used to give a boost to patients with immunodeficiencies. Well, high-dose therapy does the exact opposite. By delivering such a massive concentration of antibodies, it actually acts as a powerful immunosuppressant. It's used to calm down severe autoimmune conditions, actively block the patient's own damaging antibodies, and rapidly reduce dangerous inflammation. It is absolutely life-saving. And because its NTAP just recently expired, its coding pathway has completely changed. And this brilliantly illustrates exactly how that transition works in your manual. We're saying goodbye to the deleted temporary code we used in the new technology section. That's table XW1 with anatomical regions W, transfusion 1, and the specific high-dose value D. Because that NTAP expired, we have a brand new permanent home for this procedure. We now report this in table 302, using the body part values for peripheral vein 3 or central vein 4, and we assign it the new qualifier value 5, representing immune globulin high dose. The temporary XW code is completely gone, and the permanent 302 code takes its place. All right, Section 3, NexoBrid for severe burns, and the Table 3EO updates. Let's look at Table 3E0, Administration, Physiological Systems, and Anatomical Regions, Introduction. NexoBrid, or Anacaulase-bcdb if we're using its generic name, is a really unique, topically administered botanical drug. It has FDA approval for a very specific, intense clinical use. It chemically removes dead tissue, which is known clinically as eScar, from deep, partial thickness and full thickness, severe thermal burns. Just like our previous example with the immune globulin, NexoBrid originally had a temporary code tied to an add-on payment, and, you guessed it, just like before, that payment period has officially ended. Let's see how this builds on the exact same logic we just walked through. There's your deleted temporary code. You are probably used to reporting this botanical drug using table XW0, anatomical regions W, introduction 0, and the specific value 2. Definitely make a note that this code is now deleted. Going forward, the new permanent home for NexoBrid is table 3E0. You'll use body part values skin 0 or subcutaneous tissue 1. And here is the real game changer for your manual. A brand new qualifier value was added to this row specifically for this migration. It's other enzymatic/chemical agent, which is value F. Actually, let me pause right here for a quick question. If you are a medical coding student and you're finding this breakdown helpful, please do me a quick favor. Hit that like button on this explainer and subscribe to my YouTube channel for daily updates. I'm constantly breaking down these complicated manual updates so you can walk into your certification exams and your everyday workflow with total clarity and complete confidence. Okay, Section 4, Coding Takeaways and Updates. Let's master this migration. So the crucial point here is, how do we take these highly specific examples and apply them practically to the way you approach your coding manual every single day? You have to understand the underlying system rather than just trying to memorize a random list of updated alphanumeric characters. Whenever you're dealing with these updates in the administration section, I want you to use this simple 3-step framework. Step 1, identify the expiration of the NTAP. That is always your trigger. It tells you a code is about to move. Step 2, recognize the deletion of the temporary XW code. Just cross it out mentally. It's no longer valid for current discharges. And step 3, apply the new permanent 3 administration code, paying incredibly close attention to those brand new qualifiers, like our new value 5 for high-dose immune globulin or value F for the botanical enzymatic agent. Follow this structured logic, and you will always know exactly where to trace the new code in the permanent tables. Which leads us to a final kind of provocative thought to leave you with today. With NTAPs continually expiring as time goes on, which new technology code sitting in your manual right now is getting ready to transition to the permanent tables next? Medical coding isn't just data entry, guys. It's a living timeline that constantly tracks the bleeding edge of medical innovation. So stay curious, keep tracking those temporary add-on payments, and you'll always be one step ahead of the curve. Thanks so much for joining me on this explainer today, and keep up the fantastic work with your studies.